You're going to be that person, and you're going to probably have the tool. You probably have more tools than you think to figure this out. You have a doctorate in physical therapy. Yep. So don't forget about that. You're listening to the Pelvic Freak Show
with your hosts, Amanda Neary and Hannah Meyer. Hey, Pelvic Freaks. Welcome back to another episode of the Pelvic Freak Show.
Where you're freaks for us and we're freaks for your pelvis, baby.
Hannah's here rubbing her raw dogs on my leg right now.
What do you mean? Oh my God.
Your dog is so close to me.
I have a wart on my toe again.
Ew, get it away from me.
Don't put that in.
Okay, fine.
Don't put that in the podcast. Actually, I don't care. We're normalizing it.
We're normalizing it.
I'm getting a wart Band-Aid tomorrow.
We're destigmatizing it. Sorry, I said
because it's not normal to have warts on your feet.
Sorry, I said you. I didn't mean that.
Yeah, you made me feel bad about my feet.
I'm sorry. My feet are really ugly, if that helps.
Facebook Marketplace. Let's talk about it.
Okay, what do you want to talk about?
It's tough out there.
Yeah, it's as savage as the housing market.
Here's my opinion. I'm a truck girl. I want a truck. I want a truck. I don't need an SUV. More people in Chicago should have trucks.
Disagree.
More people in Chicago should have trucks. We need to make them liberal. We need to make them leftist. Can we have leftist trucks?
My issue isn't the vehicle, it's the space in Chicago for trucks. They take up so much space.
A small-ish truck.
I don't want them to take up my street parking.
Because I want to pick up this table, I want to pick up this couch, but I have an SUV. Why do I have a lid on my car? I just need to remove the lid and I'd have room.
But can you not put the seats down and like fit a good amount in there?
You know, I probably could.
That's what I do. I picked out my car because I drove like a small car for the first 10 or 12 years or whatever of having a car. And I hated like picking stuff up and moving stuff. Mm-hmm. Then I got an SUV and I made sure at the dealer, I was like, let me see how much space when the seats are down.
Yeah.
I got to fit my bike in there. I got to fit a table and chairs when I move, just random shit. And it is better, but like obviously it's not going to be a truck, you know?
I just think that I would look so good in a truck, like driving a truck.
That's fair.
I think that I want to be the truck girl of the friend group.
I think that's valid. I think I'll modify your statement. There should be more designated truck people of friend groups in Chicago.
There should be.
But they should park it somewhere else.
When I did live in Kentucky, I always had a friend with a truck. Mm-hmm. It's Kentucky. Every other person owned a truck. If you put them in a line.
In LA, we had a friend with a minivan.
It's the same. It's the same thing, but the Western U.S. version,
the regional version. No, I like a truck. They make like hybrid trucks now too. They're getting more liberal.
I need a liberal truck. Like, I want girls driving trucks. It's so sexy. Mm-hmm. Every time I bring up to the friends that I like trucks and that I want a truck, no one really like gets behind me on that.
My sister would.
Yeah,
she's a farmer.
But I live in the city. It's hard. We need city trucks. Who's listening right now? Someone out there, one of you has a connection to someone. Here's your idea. Trucks for city people. Trucks for the girls.
City truckers.
Trucks for the girls, gays, and theys.
Love that. Yeah, we don't have time for that, so someone else can do it.
Yeah, exactly. We have too much on our plate. Anyways.
Okay.
Yeah, I'm in my Facebook Marketplace era because I'm moving. So I'm just selling stuff. I'm buying stuff. I refuse to buy things new unless it's super cheap.
Yeah. I'm in the moving era. I'm a couple months behind you, but in July I'll be doing all that. So can't wait to furnish again.
Can't wait to show you guys our new podcast studio made of Facebook Marketplace stuff and my new apartment once I decorate it.
Yeehaw.
But anyways, getting off the truck tangent, we're here today. This episode's for the PTs.
This episode's for the PTs because we've had some listener questions from clinicians who listen to our podcast. Love y'all. And they had some questions about pelvic floor therapy.
This one's for the pelvic floor PTs, the aspiring pelvic floor PTs, the students, the new grads, wherever you are in life.
And honestly, anyone who's interested in how we get to the point that we're treating pelvic health.
Yes.
It might not be as targeted for you, but cool to know.
Yeah. So this one's for you guys today. And I'm going to pull up a question that we got. We just have 2 questions we're going to go into today, and then we'll just dive in based on that. All right. Here is my first one. Hi, Anon, please. I've recently become a huge fan of you guys. Woo! Snaps for that. To keep things brief, thank you. We're fans of you. To keep things brief, I graduated PT school in May 2025, have been licensed since August, and just took the pelvic function level 1. Is that what it's called now? Pelvic function level 1?
Through who?
Herman and Wallace.
I guess so.
I love all caps pelvic floor PT, but have no actual mentor and feel very alone. I don't have a huge pelvic floor caseload yet, ... But I'm seeing both men and women, in parentheses, some limitations with male evals, obviously because I've not been trained in rectal exams yet. Is it okay for me to be seeing any pelvic floor patient and just treating what I feel able to treat, then referring out if necessary? I'm not sure if I should be limiting myself since I've only taken the fundamentals course. Just need some guidance, ... Appreciate any help or advice you're willing to offer.
Okay, first I do want to see what the Herman and Wallace courses are now, because that's not what it was called when I took it.
No, I think it was just called pelvic floor level 1 when I took it.
Pelvic function level 1. Okay. Beginner course, PF1. I mean, it was called PF1 when I took it. I don't know.
Maybe I wasn't paying attention that much.
Maybe. And then level 2. So when I took it, I know it's different now, but when I took it, it was level 1, level 2A, 2B, and then capstone, which was what like prepped you for the exam. 2A was the male pelvic health and rectal exams course. 2B was more on vaginal.
More higher complexity and pain.
Right. And it covered more of like pregnancy, postpartum too. But I think this is a really good question for people going into pelvic health, especially if level 1 was your first exposure to it. I can start if you want.
Yeah, go ahead and start.
My answer is definitely don't limit yourself automatically based on what you've taken. You're going to need to get reps in to figure it out. And when you think about how you got into musculoskeletal conditions, you had to do the same thing. You would eval someone. If you had a question, you would go to your CE or someone, ask that question, or refer that patient to someone that you work with. So I guess the follow-up for you would be like, who else in your practice can see them if you feel like you can't see the condition. If you're really worried about specific conditions, you can maybe have them like put a little more detail in their intake paperwork so you can decide up front if they're a good fit for you or not. But you're not going to feel confident with pelvic health till you start seeing patients. So I personally wouldn't limit. I think you need to get the reps in to understand what you need more education on too. And then for rectal exams, fun fact, I never took the rectal course. I was just taught by my colleague at our office, and then I started treating patients, and I already had a good foundation from 1 and 2B. So I felt confident with my pelvic floor care, and I just added in rectal. And she had me like co-treat a couple of patients with her and have them tell me what the pressure was like compared to her pressure, so that my exam skills were still honed a little bit, but about as much internal practice as you would get in the weekend intensive anyway. So I think there's different ways to do it.
If not more.
Yeah.
You probably got more practice reps in.
Probably.
That way. I would say that happens with a lot of pelvic floor PTs. I call it the grandfathered in or grandmothered in situation. Grandfathered in.
Grandfathered in has racist roots.
Literally, what? I hate that. Can we say grandmothered in, or is it still racist?
You could say granny did.
Granny did.
For today. It was granny did.
Okay. Moving on. A lot of pelvic floor PTs, you learn most from mentorship, I would say. Which I know this question is saying they're lacking mentorship where they are. How would you recommend them to seek out mentorship? Because the courses take a while to get to sometimes, whether it's cost because they are expensive. Maybe where you work does pay for continuing ed, but you have to wait until the next year to take it. But you have these patients that would benefit from that class. What do you recommend?
I definitely recommend, however you did your Herman and Wallace cohort, One, if you had a cool instructor, one of my instructors is one of like the higher ups at Herman and Wallace, and I was able to just email her questions for a while after, and she would always answer and respond. So if you had a good instructor that seems receptive to that, you can definitely use them as a mentor, or even like send them a coffee gift card and then get an hour of their time on Zoom or something. Ask your questions, because your mentorship with pelvic health, it's going to be less manual therapy focused than it is clinical reasoning, because you're working on a new system that you didn't learn in PT school, right? So most of our questions that come up are like, what do I do in this complicated case? So having conversations with other PTs that have been treating a little bit longer can be really helpful. And then other people in your cohort, maybe your lab partner, you can make a little support group or a texting group chat of like, hey, had this kind of case today. Has anyone seen this before? Other PTs use the resources you already have, and then you can also find Facebook groups and things like this podcast, like just areas where you can get a little bit of exposure, find people to connect with. Oh my God, idea alert. Should we make a pelvic floor PT support group?
Yeah, I was thinking of having, I think we mentioned this on a previous episode, of eventually having our own Facebook group. Should we do that once this episode launches?
Maybe. Let's do it.
Maybe we do that. Maybe we'll follow us on Instagram if you're not already for updates on that. Mm-hmm. In the meantime, I am in a Facebook group called Pelvic PT Huddle. It's over 10K pelvic floor therapists. So people are always asking questions in there, and people are always commenting, whether it's even patient cases, having difficulty with a specific patient case, or even just like recommendations on different, I don't know, tampons, do you like random questions, right? Anything. Like you can even search the Facebook group and you can find something, or you can ask your own questions in there. Maybe we'll post our own Facebook. We'll start our own Facebook group so you can have access to that just within our community. So it feels more like a community to you rather than joining a new community that's already existed and really, I don't know, thick up in it.
Thick up in it. That would have been a favorite of mine. Yeah, I think Hannah and I will do brainstorming right after we film this episode. I love this idea of a community. And if you guys are like, we hate Facebook, let us know. I know there's different free platforms we can use, but I think it'd be cool to just have somewhere to communicate with all the pelvic floor PTs that listen to our podcast.
Yeah, that would be great.
Or maybe there's something on Instagram now. Maybe that's a feature where we can make like a group chat.
Maybe we can.
We can see.
Again, follow us on Instagram if you aren't already for those updates to come. So that's some tips. Amanda mentioned Facebook groups. I told you Pelvic PT Huddle, which was started by the owner of Pelvic Sanity, which is a clinic in LA. Her name's Nicole Cozine. She also does the Pelvicons every year that always sells out. So a lot of pelvic floor PTs are in there.
I don't know why I just did that.
Amanda's losing brain cells.
Guys, I have period brain to the max today. Like, I actually was stupid yesterday. I was like helping my mom set up for my brother's engagement party, and I was completely useless. She was like, I don't need anything from you but for you to move the air purifier out of the living room, and I forgot to do it.
She was actually like, please just do this one thing.
Yeah.
That's all right, Amanda.
That was my sidebar.
You're doing okay. Okay, so moving on. I'm not done with this question yet.
Okay.
Let's go back into this. Is it okay for me to be seeing any pelvic floor patient and just treating what I feel able to treat, then referring out if necessary? I feel like you answered your own question. You're using your own clinical reasoning and judgment. Snaps for that. If you get an evaluation and you're like, okay, maybe I'm newer to this. This is something that I know how to at least to get this patient started, but maybe I'm not the most prestigious in my field on this right now. But use the eval, get what you can from that eval, ask questions to other PTs, to other mentors that you can find, even though you don't have a direct mentor with you. DM us if you want, in our new group that we create. And then if you're really like, okay, this patient needs more support than I can give, refer them out somewhere else. But it truly, think about how hard it is for a patient to find a pelvic floor PT. You might be the only one in that area for this patient right now, and you're going to be able to help this patient in at least some shape or form.
Yeah, love that. Yeah, I do feel like they answered their own question a little bit, and that's always how it goes. It's like, should I do this, or what if I do this other really brilliant idea?
It's like you know, girl, you know. But it is probably coming from like the insecurity, like I've only taken the fundamentals course. Like you're going to get better and better with the more patients you have, the more experience you gain, the more clinical expertise you gain. So take the next course, of course, when that comes available to you, because that's going to make you even more confident in your skills. Obviously, rectal assessment is vital, very important as a pelvic floor PT. I recommend taking that as soon as possible, as soon as you can, because that is limiting you. Because especially if you have someone that doesn't have a vagina, that's the only way you're going to be able to assess their pelvic floor. In the meantime, you can do an external assessment. You can still teach them diaphragmatic breathing and cueing. You just aren't going to be able to feel exactly what's happening in their pelvic floor. You could if you had someone guiding you through it in the moment. Like when I had my student, I taught her rectal exams. She hadn't taken the level 2A yet or whatever it is now, but she had one-on-one mentorship with the patient with me. So it was completely safe, had guidance, didn't feel insecure about the treatment. We knew what we were doing, right?
Yeah.
So I hope that answers your question.
Yes. As if I answered the question. Yes, it did, Hannah. Thank you.
Okay. Again, thank you so much for saying you're a fan of us. That makes us so happy. And I'll message you right now and let you know that this will be answered on this episode. So,
Sweet.
mwah. Okay.
Mwah.
Let's go to the next question because it's kind of aligned too.
Okay.
And this person did not want a shout out or didn't necessarily say a shout out. So we're still going to keep this person anonymous as well. Would you like me to read it?
Sure.
Because you like hearing my voice, even though I smell like your grandma.
Oh, yeah, you do.
Okay. Hi, I am a physical.
No context.
I tried a new perfume that I was really excited about, and Amanda shut it down.
I didn't say it was bad. It just does smell like my grandma.
It's fine. Hi, I am a first-year physical therapist interested in becoming pelvic floor certified. I was wondering what organization you both took your certification courses through, or where you recommend. Also, how long did it take for you guys to get a complete certification? Do you recommend taking the courses back to back or spacing them out? Sorry for all the questions. Thanks for your time. Obsessed with your podcast as well. Thank you. We're obsessed with you.
We're obsessed with you. I love all of those questions. They're all really good. Starting with where did we take it? We both did Herman and Wallace, right?
We both did Herman and Wallace.
But we have PTs at the clinic that have done APTA. They're both fine. The feedback I get from people that did APTA is that it's a little more analytical, content heavy. Like if you're more of a bookworm, you would like the APTA one more. Herman and Wallace is more like vibes.
More relaxed, more hands-on, more interactive of what my experience was. Yeah.
Those are the two gold standards. Still, I check this often because I'm always checking to see if the Institute of Clinical Excellence is one of the gold standard courses yet, because when I hire people, I want to make sure they took one of the gold standards. So Herman and Wallace or APTA are both totally fine. The other ones that we love are the ICE ones, Institute of Clinical Excellence, especially if you're working at a place that sees athletes, but you're going to need the internal treatment assessment skills from Herman and Wallace or APTA as of right now in April 2026. I almost said June. Why do I think it's June? That could change. So
let us know if you guys have taken a course through Institute of Clinical Excellence.
Clinical excellence.
Well, I want to say ICE, but that's bad. The overlap. You can't say like ICE, obviously.
Yeah, I used to. Now I say ICE.
You have to say ICE.
Yeah.
That's unfortunate.
Yeah, it's unfortunate branding, timing. But they're really good. They're really good with continuing ed stuff. So yeah, let us know if you did take one, or if you took one outside of those three that was really good. We can shout it out on the podcast too and let people know it's an option for continuing on, because you're not going to get everything from Herman and Wallace or APTA. No matter how many courses you do, there's going to be more to learn and more places to learn that through. And I would say neither of them are particularly gym savvy and programming savvy.
I like those courses specifically, like for what Amanda was saying, get the internal treatment rep. So the first time you're not doing internal treatment is on a patient, and it's scary. It's so you're getting used to it, getting more comfortable with describing the internal assessment to a patient, getting the setup correct, making sure the setup works for you. Like Amanda sits in a stool and has people with in hook lying position. I sit on a table, have a patient with the butterfly position and one knee on my knee. And I've had some PTs that have done standing position. So finding out what works best for you so that the patient doesn't feel uncomfortable as well. Those are super important. As far as wondering how long it took to get a complete certification.
Ooh.
Good question.
Good question. We don't have complete certifications.
Not really. I mean, it's a thing in a way to where you could get your WCS, your women's certified specialist, but you would have to sit for an exam for that.
Or your PRPC through Herman and Wallace.
Or your PRPC, which is Pelvic Rehabilitation Practitioner Certification.
Which I was going to do this year and decided to wait on because one, you don't really need it. And two, things got busy and I didn't feel like studying for it this year.
Yeah. So yes, you can get certified, but it does take time. You do have to sit for another exam. If you're a new grad PT, I feel like this is where a lot of people get confused as students. You don't have to be completely certified in order to start treating pelvic floor patients. Actually, I think you need to gain more clinical hours before you can even sit for the exam.
Yeah.
So this is where the confusion becomes because I get that because as a student, I remember being like, oh, I got to get dry needling certified. I got to do this. But the same thing with dry needling, you don't need to be completely certified. You actually do need to gain more hours. And there's 3 courses that you have to take before you can even sit and take the test through MyoPain seminars to become dry needling certified.
Yes.
What is the certification? It's letters at the end of your name. You can throw it in your bio. Patients may have more confidence in you knowing that you are PRPC certified or you have your WCS, knowing that information. Otherwise, you know, it's not much, you know?
If you think about your physical therapy boards, it's like studying for the board exam, but it's all pelvic health. So it's a ton of content. It's not necessarily latest research. They try to make it latest research, but it's not always what you're using in clinic today. So it's good to have if you are someone that wants the authority or feels more confident saying you're a pelvic floor therapist. If you have those letters after your name, letters are nice, but they're not the end of the world, right? From a hiring standpoint, as someone who hires PTs, I care so much more about that person's compassion and rapport building with patients than whatever certification level they've reached or whatever continuing ed they've done so far. As long as they've taken level 1, everything else is trainable to me. I don't need letters after someone's name for that. But depending where you are, how competitive your market is, there might be some advantage to getting that certification. And also notable, you can take all of the courses pre-certification and still not take the exam. So that person is basically just as qualified as the person who sat for the exam.
Yeah.
So I hope that answers your question.
Yeah.
Not something we really value that much.
Yeah, but if you are like, I want to be a leading voice in pelvic health and I want people to know it and I want to have confidence in saying that and sitting for the exam and getting that full certification gives me that confidence because that's who I am, then pop off. But otherwise, what me and Amanda both agree on is, yes, take your level 1. Yes, take your level 2 for sure. So you know how to do rectal exams, you know how to do vaginal assessment, all of those. And then the other courses as you go, as you treat on top of your clinical expertise you're gaining. And then you can take more pelvic floor courses where you feel like your knowledge is lacking or you're like, okay, I'm getting a lot of patients with prolapse. I need to take a course that goes into detail with that. I'm getting a lot of patients with urinary dysfunction. I'm getting a lot of patients with vulvodynia. Find a course through Herman and Wallace that goes deeper dive into that if you feel like you're lacking that, or if you feel like you're not getting that through your mentorship, through your practice, or you don't even have mentorship.
I feel like that's a good leeway into the next question, which is if we should take courses all at once, back to back, or wait a little between each one. I would always recommend waiting a little bit. Aside from your foundational courses, if you don't have someone to mentor you on rectal exams, I would do 1 and 2 rectal, whichever letter that is, right away. And then go treat for a while because you're going to want those reps. The course is going to be so much more beneficial to you if you know what you're struggling with going into it. So if you just are like, okay, I'm going to take 1, 2, 2B capstone and then sit for the exam. Sure, you can be a PRPC in less than a year if you want to do all of that. But this is where letters after the name don't mean anything to me, because you don't then know what your treatment style is like, what conditions you struggle with. You didn't get as much out of those courses because you just did them for academia. And we know going to PT school, you learn so much more on your clinical placements treating patients, right? So same thing with pelvic health. I always recommend spacing them out.
Yeah. Get your fundamentals down so you know how to explain the basics. And then going back to our first question that we had, referring out if you feel like you are not the candidate for this patient, or you truly, truly feel like this patient would benefit from someone else. But knowing where to refer them to. If you, though, are in a really rural area, you're going to be that person. And you're going to probably have the tool. You probably have more tools than you think to figure this out. You have a doctorate in physical therapy. So don't forget about that.
And when it comes down to it, treat what you see.
Treat what you see.
If someone's saying, I have pain with this, and you're like, I haven't treated that specific condition yet, go back to, I have pain. What can you do for that pain? What can you do up to this point? And then you can see next week how it went, and then you can assess again.
And then keep building upon that.
In the meantime, maybe you ask some questions to a community online and you get that mentorship.
In my opinion, that's how I learn best too. Is by using my brain and figuring out for myself, and then using the tools I have, versus sitting in a lecture and watching PowerPoint slides and then trying to memorize everything from a lecture. That's also much needed, especially for fundamentals, but going to that eventually later on, and then being able to apply it from patient cases that you remember that you were struggling with, etc. So I hope that helps.
I hope that helps.
And
These
I hope
were
that makes
actually
sense.
both really great question stories.
And questions that I've had in the past too.
Yeah.
Especially when you're looking for a job in pelvic floor PT and you're worried about not having enough clinical experience, or you're worried because you're a new grad, but you truly do want to just be in pelvic floor PT world and not ortho world, you know?
Yeah.
Which I think is fine. If you know you want to be a pelvic floor PT, there's so much within the pelvic floor PT world. A lot of people, I do think it's beneficial to have an ortho caseload at the beginning, just because you were in PT school for 3 years, and that's kind of what PT school does prep you with, and ortho skills do come in handy. But as far as it comes to like pelvic floor PT, there's so much.
Yeah. And ortho, you're going to have pelvic floor patients that say, okay, this is feeling better. Now my shoulder hurts. So get comfy with it. Even if you end up having to refer that out, you want that baseline too.
With pelvic floor PT, you treat patients for a long time eventually, or maybe you treat a patient that's pregnant and then postpartum, and then they know you as your PT, and maybe later on they don't have a pelvic floor issue and something will come up where they're like, I'm having a lot of shoulder pain because I was breastfeeding and only holding my baby on one side. Can you help me with that? It's nice to have that fundamental knowledge so you can be like, yes, if you want to, like you can help treat that person's shoulder, and then refer out if it's way above your brain load.
Yeah.
Like you can treat shoulder pain, but maybe it's like full-blown post-op or something. Maybe then you'll refer out, but typically you could probably treat that person's shoulder.
And I would argue that you really should be able to. Because pelvic floor should make you a better ortho PT, but it is a branch of orthopedics. It's not like a fully different thing. It's not MSK, right? Like you're not doing specific joint pains for shoulders, elbows, wrists, but that stuff you will be more confident in right away if you went to PT school.
Yep.
So just keeping up those skills, I think, is important for pelvic PTs.
It really is.
Yeah.
It really is.
All right. Did you guys find this useful?
So what we learned is that we think we need to make a group for you guys, because we are continuing to keep getting questions in the realm of what it's like to become a pelvic floor PT, or even just caseload questions.
Yes. I kind of love the idea of a group for our pelvic floor PT freaks. Are the other freaks going to feel left out? Would you guys feel left out if we made a group for clinicians, or should we have 2 different groups? You let us know. Would you want your own group for people struggling with pelvic floor dysfunction, or like a listener of the podcast that isn't clinical, and then a clinical group, or just a clinical group, or what?
We're going to do a poll on our Instagram, and we'll probably do the poll a few times.
We'll do the poll a few times.
And then we'll figure it out for you guys.
Great.
Awesome.
Guys, leave us 5 stars. We want to expand our reach and it helps us so much. So if you liked this episode, give us that rating and maybe share it with a friend.
And if you hated my random truck rant at the beginning of this, I'm so sorry.
I liked it.
Cool.
I think it's good.
All right. Bye, Pelvic Freaks.
Bye, Pelvic Freak.